So I think Sai has come. Yeah, Sai is here. So next speaker is our outgoing president, Dr. Saikumar, and he doesn't require any introduction. He's an excellent speaker, a fantastic surgeon, and he's going to talk on incisions and hydroprocedures. Over to you, Sai.
Thank you. I'm sorry for being a bit late because the executive committee meeting is going on. So I'll finish the talk and go, and maybe one or two questions, if with the permission of the chair, we can take. So basically, this is a talk on phaco basics, so I'm going to stick to just the basics, nothing, no fancy stuff. So I'm going to talk about the paracentesis, the main wound, and the hydroprocedures. So just a few pertinent points about the paracentesis and the main wound. We are all presuming that we are going to do the phaco from a temporal location. Although there are many of us, when we started phaco, we started with superior, then shifted to temporal. But I think the general trend now is that you have a temporal location. If you are a right-handed surgeon, your right paracentesis will be somewhere around 6 o'clock, and your left paracentesis will be slightly closer towards you. Again, the location of the paracentesis is not a sacrosanct rule. You can have it according to your convenience. There are surgeons who have it very close to the main wound. There are surgeons who have it slightly away from the main wound. There are also surgeons who don't use a right paracentesis at all. So you have the main wound and the left paracentesis alone, and the rexus is done through the main wound. And for the phaco, you only need one, but I generally you do 2 paracentesis. What is the blade that you want to use for the paracentesis? You have 2 options. You have either a straight blade or an angled MVR, and the length and breadth of the wound is very, very important. Okay, so we'll just play a very, very short video. So this is a straight 15-degree blade that is being used. Always stabilize the globe when you're doing your paracentesis. Especially when you're doing your initial cases, you can either, if you are under a peribulbar block in your learning curve, you can use a tooth forceps. Otherwise, you can use a small bud to stabilize the globe while you're doing it. And in topical phaco also, make sure the patient is not moving inadvertently while you're doing this important step with the sharp instruments. So once your paracentesis are done, then you go at the main wound. I would advise you to have a blade which has got a marking. Many of the blades are available with markings now. This marking is about 2.5 millimeters from the tip of the blade. So that will give you, if you are making a 2.4 or a 2.2 incision, it will give you something like a square incision, which is very, very stable as far as the cataract surgery is concerned, and the sealing of the wound is very important. So this is the angled MVR. I use the angled MVRs mostly in all my topical cases and also in sunken eyes. When you are using the side entry in a very sunken eye, you find it difficult to use a straight one, and then you can use an angled MVR in such cases. So this is, again, you have an opening of about 1.5 millimeters, and the angulation should be sufficient enough. Here again, you can see that the marked blade is being used for the main wound here. So what are the wound-related issues you are likely to have? You can have either a long or a short paracentesis. Short paracentesis do leak. You can have a bit of iris prolapse if the breadth is more. And especially if you are doing a case of IFIS, you can have the iris coming on into the wound quite often. If it's, if the breadth is too much, you can have wound leak during phaco. You can have shallowing, because each time you move your second instrument, you can have a shallowing of the chamber. If it is a very long wound, you can have what is called overlocking. You might find it difficult to put in your instruments. Your maneuverability inside the chamber comes down. And if it's a very tight wound, especially nowadays, if you overfill the chamber with some of the newer OVDs, you find it, you see that the phaco tip gets blocked, and there can be a bit of wound burn also. So just a few pertinent points about hydrodissection. The word itself is called cortical cleaving hydrodissection. So you can use either a normal cannula, the rounded cannula which we use for our air injection, or a trypan with the same cannula can be used, or you can also have a beveled cannula, which is slightly easier to place it under the capsular rexus. Do it at multiple points, definitely 2 if necessary more. Always inject small amounts of fluid. Don't inject too much of fluid and increase the pressure in behind the nucleus. And always decompress every wave of fluid you make, even though you have seen the wave come out through the other end, always decompress the center of the nucleus so that you don't let the pressure build up behind. If you have too much pressure behind, you can have what is called a capsule blowout. It can occur commonly in a posterior polar cataract, but if you have a very small rhexis and you inject too much of fluid, especially in hard cataracts, you can still get a blowout in other situations as well. Do not use too much heavy OVDs in the chamber. I prefer HPMC during my hydrodissection. You always depress the lip of the main wound so that don't let too much pressure, build up inside the chamber. So this is the again a short video clipping of hydrodissection. This is a beveled cannula that I am using. You can go under. You can see that the wave is seen, and then you go to the other side and then again decompress. This is the normal rounded cannula. This also can be used for your hydrodissection. Again, at 2 points, the hydrodissection is being done and the center is depressed. There are some special situations of hydrodissection. The first one is hydrodissection in posterior polar cataracts. You can actually do a PPC without doing a hydrodissection at all. But in case you want, you can do a very, very minimal I would call it a hydro procedure. It is not even a hydro delineation, just loosening up the anterior epinucleus there. And then without rotation, you can make the trench there and you can slowly rotate the nucleus into your phaco tip and do a good phacoemulsification. This is again a case of a hydro delineation, again a posterior polar cataract. You may not get an exact golden ring in every case, but if you can find that right plane, maybe in the second or third attempt, you will see that you are cleaving that nuclear part from the rest of the epinucleus. Again, two situations where I advise you not to do a hydrodissection. You have these very hard brown cataracts with lot of thick epinuclear intumescence around it. We do a double rhexis in these sort of situations. After the first rhexis itself, you are sort of decompressing and using either a bimanual or a Simcoe cannula to decompress. And in these situations, you don't need to hydrodissect. And again, you don't need to hydrodissect in Morgagnian cataracts, where you immediately, as you do, you can see the lot of leaking fluid from there. And in these situations, you'll just find a small nucleus inside. In femto, what I do is I make a small trench in the center initially, because there is some air that is collected behind. I don't hydrodissect with the air, although many surgeons believe that it is safe. So I do a small trench there. I let out the air first and then do a very limited hydrodissection. So in summary, hydro procedures and wounds are very important. Multi-point small fluid quantities to be used. It makes cortical aspiration very easy. If you've done a good hydrodissection, your cortex aspiration is very easy. You should know when not to hydrodissect at all, and you should also do a very careful delineation in select cases. Thank you very much for your kind attention.